Welcome to the Deep Dive, part of the Luma Clinic's podcast series. So today we're tackling pandas and PANS. And if you've heard these terms, you probably know they can be, well, incredibly confusing, right? Even for doctors.
Oh, absolutely.
Very confusing.
So our goal today is really to cut through some of that confusion. We're digging into the latest research, clinical guidelines, pulling out the really vital stuff so you can walk away feeling, properly informed about these challenging pediatric conditions.
And it's such an important topic because it causes so much distress for families, for clinicians too. I mean, just imagine your child suddenly, really dramatically, develops these severe neuropsychiatric symptoms.
It sounds terrifying.
It is. And the search for answers, it's tough, especially with all the scientific debate still going on. So yeah, our mission here is to give you a clear, comprehensive overview, help you understand the landscape.
Okay, so we know they're challenging. Let's start at the beginning. What are pandas and PANS? We need to define these terms before we get into the deeper science and the treatments. Right. So let's start with PANS. That's Pediatric Acute Onset Neuropsychiatric Syndrome. Think of it as the broader umbrella term.
Okay, the umbrella, and what falls under it? What does PANS actually look like?
Well, it's basically a situation where a child has this really sudden, really dramatic start of psychiatric and neurological symptoms.
And are there specific symptoms that flag it as PANS?
Yeah.
Key things to look for?
Yes, definitely. The sort of cardinal symptoms are an abrupt onset of OCD, obsessive-compulsive disorder, or severely restricted food intake. Sometimes kids just suddenly stop eating much.
Right. OCD or eating issues. Very sudden.
Exactly. But it's usually not just those. Alongside one of those, you typically see the sudden appearance of at least 2 other symptoms from a list of 7 categories.
Okay. What kind of things are in those categories?
So you might see significant anxiety popping up out of nowhere, big mood swings, emotional lability, or maybe depression, irritability, aggression, severe defiance, like way beyond typical kid stuff. You might also see developmental regression, so kids losing skills they already had. A sudden drop in school performance is common too. Then there are sensory or motor abnormalities.
Like what specifically?
Well, things like handwriting suddenly getting messy, new tics showing up, maybe being super sensitive to sounds or textures, sometimes even hallucinations, though that's rarer. And finally, there are physical signs, somatic signs like sleep problems, bedwetting starting again, or needing to pee all the time.
Wow, that's a really wide range of symptoms, all hitting at once.
It is, and that suddenness is really the hallmark of PANS.
Okay, so PANS is the big picture. Where does PANDAS fit in? You hear that term a lot too.
Right, so PANDAS is a specific subset of PANS. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Streptococcal Infections.
Ah, strep. Okay.
Exactly.
Yeah.
By definition, PANDAS is linked directly to a group A strep infection, the kind that causes strep throat.
So what are the criteria for PANDAS specifically, beyond the strep link?
For PANDAS, you're looking for OCD and ortics, like we mentioned for PANS. But also, the symptoms have to start before puberty. There's usually an episodic course, meaning symptoms flare up badly, then maybe get a bit better, then flare up again.
Right.
And crucially, there needs to be a clear timing link between a strep infection and when the symptoms first started or when they got worse. Plus, there's often an association with neurological abnormalities like jerky movements, they call them coriform movements, or motor hyperactivity.
That sounds a bit like sydenham chorea, doesn't it? That old condition linked to rheumatic fever after strep.
That's a really important connection, actually. Yes, sydenham chorea is, it's a known post-streptococcal autoimmune neurological disorder. Kids get these involuntary movements after a strep infection because the immune system mistakenly attacks the brain.
Sid Vitus's dance, they used to call it.
Exactly. So the hypothesis for PANDAS is that it's a similar kind of autoimmune mistake, just targeting slightly different parts of the brain, leading to the OCD, tics, and other psychiatric symptoms instead of just the movements.
Which brings us to the why. For ages, this is the big question mark. But the main theory now is something called molecular mimicry. It sounds complex, but it's kind of like mistaken identity.
That's a great way to put it. Yeah, molecular mimicry. The theory goes like this. After a strep infection, your body makes antibodies to fight the strep bacteria. Perfectly normal.
Right.
But the problem is, some proteins on the strep bacteria look very, very similar. They mimic proteins that are naturally found in a part of our brain called the basal ganglia.
Okay, so the antibodies get confused.
Exactly. They're designed to attack strep, but because of this resemblance, they accidentally start attacking the child's own brain cells in the basal ganglia. And that attack is what's thought to cause the neuropsychiatric symptoms. It's the immune system basically attacking the self.
And now there's some really compelling science starting to back this up, right? I know there was a significant paper, you and colleagues, it really dug into the antibodies and what they're doing in the brain.
Yes, that study was a big step forward. It provided some pretty strong evidence supporting that whole molecular mimicry idea and the autoimmune mechanism.
What did they find exactly?
They found that specific antibodies, a type called IgG, immunoglobulin G, taken from kids with carefully diagnosed PANDAS, showed significantly higher binding to one particular type of brain cell.
Which type?
They're called cholinergic interneurons, or CINs for short. And this binding was happening specifically in the striatum, which is part of that basal ganglia region we mentioned.
Okay, so not just anywhere in the brain, but targeting these CINs in the striatum.
Precisely. And just as importantly, they found this binding did not happen nearly as much to other types of neurons nearby, like certain GABAergic interneurons. So it looked quite specific.
That specificity seems huge. Was it just a one-off finding, or did they confirm it?
No, they really nailed it down. They replicated the finding across 3 separate groups of patients and controls, using different lab techniques, even analyzing the results blinded so they wouldn't be biased. It held up.
Wow. Okay, so the antibodies are sticking to these specific cells. The next obvious question is, does this relate to treatment? If you treat the PANDAS, does this antibody binding change?
That's exactly what they looked at next. And yes, they found a direct correlation. When kids with PANDAS were treated with IVG, that's intravenous immunoglobulin, and immunotherapy, the treatment actually reduced how much their IgG antibodies bound to those CINs.
And did that reduction line up with how the kids were doing?
It did. The amount the binding went down directly correlated with how much the patient's symptoms improved clinically. It's a powerful piece of evidence linking the antibody activity to the actual illness.
So the antibodies aren't just there, they seem to be actively involved in the symptoms. Did the researchers see how they affected the neurons? Like, what did the binding actually do to those CINs?
Yeah, they investigated the functional impact too. They found that exposing brain tissue to serum from PANDAS patients actually decreased the activity of those striatal CINs. They used markers like phosphorylated ribosomal protein S6 and looked at electrical responses.
So the antibodies were basically slowing down or dampening the activity of these specific neurons.
That's what it looked like, yes. It's like they were putting the brakes on these particular cells. And crucially, when they removed the IgG antibodies from the PANDAS serum, this dampening effect was lost.
Proving the Ig was necessary for the effect.
Exactly. And again, they didn't see a similar effect on the other nearby neurons they tested, reinforcing that specificity.
So this isn't just finding antibodies anymore. It's showing these antibodies latch on to specific brain cells and actually change how they function, potentially causing the symptoms. That feels like a real breakthrough.
It really is. It provides a tangible biological mechanism. It helps move PANDAS from being just a description of symptoms to something with a clearer, though still complex, physiological basis rooted in autoimmunity.
Does this connect PANDAS to other known autoimmune brain conditions?
It seems to, yeah. It puts PANDAS in the company of other autoimmune encephalitis, like anti-NMDR encephalitis or stiff person syndrome. In those conditions, we also see autoantibodies messing with how brain cells communicate, often disrupting inhibitory signals.
So maybe a similar kind of disruption, an imbalance, is happening in PANDAS.
That's the thinking. It suggests an immune-mediated imbalance in brain circuitry, leading to these sudden, severe symptoms. But, the researchers themselves noted some caveats.
Oh, like what?
Well, they mentioned that this pattern of antibody binding might not be exclusively found in PANDAS, and maybe not every single child diagnosed with PANDAS will show this exact pattern. So there's still complexity, still more to uncover.
Right. It's progress, but not the final answer yet. Which brings us back to the clinic. Even with this science, actually diagnosing PANS or PANDAS sounds tricky. I hear it called a diagnosis of exclusion. What does that mean in practice?
It means exactly what it sounds like. Because we don't have, a single blood test or brain scan that definitively says, yes, this is PANS, Clinicians have to be detectives. They have to carefully rule out other conditions that could be causing similar symptoms before they can land on a PANS diagnosis.
So it requires a really thorough workup.
Absolutely. It starts with a super detailed patient history. You need to know everything about the symptom onset. How abrupt was it, really? How long have symptoms lasted? How severe are they? How much are they impacting the child's life, their schooling, family life?
Makes sense.
Well, you also need to review any previous mental health history, things like anxiety, ADHD, maybe autism spectrum disorder. These are actually quite common comorbidities, things the child might have had even before the PANS symptoms started. And of course, any history of infections around the time the symptoms began.
Like strep, obviously, but others too.
Yes, definitely looking for strep, but also other potential triggers. Then, a thorough physical exam and a psychiatric evaluation are crucial. These help identify the specific PANS symptoms and also help rule out other possibilities.
Does family history come into play at all?
It can be a piece of the puzzle. Some studies report higher rates of things like OCD, tics, rheumatic fever, and even maternal autoimmune conditions in close relatives of kids with PANS. It's not diagnostic on its own, but it's information the clinician will consider.
Okay, so ruling things out is key. What are the main conditions that need to be differentiated from PANS? Some of those symptoms, like anxiety or tics, are pretty common in kids generally.
That's a really important point. Yes, anxiety disorders are common, affecting maybe 7% of kids. Transient tics, even more common, maybe up to 20% of school kids have them at some point. OCD affects 1 to 3% of kids.
So how do you tell the difference?
The absolute key differentiator for PANS is the sudden, acute onset. Like, boom, the symptoms appear or dramatically worsen almost overnight. Typical OCD or anxiety usually develops more gradually.
Right, the suddenness again.
Exactly. Take Tourette syndrome, for example. Kids with Tourette's often have tics, OCD, ADHD, similar symptoms. But typically Tourette's develops more gradually, not with that PANS-like explosion of symptoms.
What about other autoimmune conditions, like autoimmune encephalitis, AE?
Good question. AE is definitely on the differential. But AE often presents differently. You might see seizures, really complex movement disorders, clearer signs of brain inflammation on tests like spinal fluid analysis or MRI scans, and often more significant cognitive decline. Also, AE symptoms tend to persist or progress, whereas PANS often has that relapsing, remitting up and down course.
And we talked about strep triggering PANDAS, but for the broader PANS category, are other triggers suspected?
Yes. While strep is the defining link for PANDAS, PANS is thought to potentially be triggered by other things, too. Other infections are often implicated, things like mycoplasma pneumonia, which causes a type of pneumonia, influenza, sinusitis.
So various bugs.
Right. Some sources even mention non-infectious triggers, like significant psychological stress or trauma, or maybe an underlying genetic vulnerability. And specific infections like Lyme disease and Bartonella are also frequently discussed in this context.
Lyme and Bartonella. What kind of symptoms do they cause that might overlap?
Well, Lyme can cause a huge range of issues, flu-like symptoms initially, but then potentially nerve pain, headaches, joint pain, and definitely neuropsychiatric things like anxiety, depression, brain fog, cognitive problems. Bartonella can cause muscle and joint pain, fatigue, brain fog too, but also sometimes things like rage, aggression, and characteristic skin markings called striae.
Yeah.
So you can see how the symptoms could potentially mimic PANS.
It really does sound like a diagnostic puzzle. Okay, let's shift to treatment. Once a diagnosis or suspected diagnosis is made, what are the approaches? I understand there's sort of 3 main types of intervention, and some are more controversial than others.
That's right. Broadly, you can think about 3 categories. First, there are the psychiatric and behavioral interventions. These are often considered first-line standard of care treatments for the symptoms themselves.
Like therapy and meds for the OCD or anxiety.
Exactly. For OCD, the gold standard therapy is cognitive behavioral therapy, or CBT, specifically a type called exposure and response prevention, ERP. It's very effective. SSRI medications like sertraline or fluoxetine are also commonly used.
Do they work well?
Often, yes. Research suggests the combination of CB-TERP and an SSRI might be the most effective, with maybe 50–70% showing a good response within about 12 weeks. CBT alone might help around 40%, and SSRIs alone maybe 20–30%. Parent education is also really key, helping parents learn not to accommodate the child's compulsions.
Makes sense. What about other common symptoms like anxiety or tics?
For separation anxiety, the focus is often on parent training, helping them support the child in getting back to school and normal activities. CBT can help too. SSRIs aren't usually the first step that might be considered if it's severe, especially in older kids. For tics, often they aren't treated unless they're really impairing.
But if they are?
Then a behavioral therapy called CBIT, Comprehensive Behavioral Intervention for Tics, is very effective. Medication-wise, alpha-2 agonists like guanfacine or clonidine are often tried first. Antipsychotics can be used, but generally less often due to side effect concerns.
Okay. And things like sleep problems or the restricted eating.
For sleep, good sleep hygiene practices and counseling are the starting point. Melatonin can sometimes be helpful. If there are signs of something like REM sleep behavior disorder, that needs a specialist. For the eating issues, avoidant restrictive food intake disorder, or ARFID, a thorough medical checkup is vital checking weight, vitals, electrolytes, maybe an EKG. Then ERP therapy, similar to OCD treatment, is used, sometimes alongside SSRIs.
And other mood or behavior issues.
Things like irritability, aggression, mood swings, depression, ADHD symptoms. Those are generally managed using the standard treatment protocols for those conditions, often involving specialists like child psychiatrists or developmental pediatricians.
Okay, so that's category one, managing the psychiatric symptoms. What's the second category?
The second is antibiotic treatment, specifically targeting group A strep, primarily relevant for PANDAS or cases where a strep infection is confirmed.
So if a child with PAN symptoms tests positive for strep throat.
Right. If they have a symptomatic GAS infection confirmed by a positive throat culture, rapid strep test, or a molecular test, then a standard 10-day course of an appropriate antibiotic like amoxicillin is generally recommended.
What if they just have high strep antibody levels but no active infection?
That's an important distinction. Current guidelines generally do not recommend antibiotic treatment based only on elevated antibody titers if there's no evidence of an active infection. However, you will find some practitioners who use antibiotics for longer durations or use different types, like azithromycin or cefdinir, but that's more off-guideline.
Okay. Now for the third category, which you said is the most controversial, therapies targeting the presumed neuroinflammation or autoimmunity itself.
Yes, this is where there's significant debate and less solid evidence. These are treatments like IVIG intravenous immunoglobulin and therapeutic plasma exchange, or TTE.
Why the controversy?
Well, some experts do recommend considering these for moderate to severe PAN cases, especially if other treatments haven't helped much. But the big issue is the lack of strong supporting evidence from high-quality studies. One key randomized controlled trial, which is the best type of study, actually did not find IVG to be effective for PANs compared to a placebo.
So the evidence just isn't there yet.
Largely, no. Plus, these treatments aren't without risks. IVIG and TTE can have significant side effects, things like severe headaches, allergic reactions, potentially impacting the immune system, blood clots. So organizations like the American Academy of Pediatrics advise caution.
What do they recommend?
They generally suggest these therapies should only be used in rare, complex cases after careful consideration by a team of specialists and ideally within the context of a clinical trial so we can learn more about whether they truly work and for whom.
Are there other, maybe less aggressive, immune-focused treatments discussed?
Yes. Some clinicians look at treatments like NSAIDs, non-steroidal anti-inflammatory drugs, like ibuprofen or short courses of oral steroids. Some retrospective studies looking back at patient records have suggested these might help shorten PANS flares. Because they're generally lower risk than IVIG or TPE, some argue for trying them earlier on.
I've also come across discussions, particularly from functional medicine perspectives, mentioning a whole range of other approaches. What kinds of things are included there?
Right, you do see a very wide array of strategies discussed in some sources, reflecting different treatment philosophies. Diet is often mentioned, specifically anti-inflammatory diets, cutting out processed foods, sugars, potential inflammatory triggers.
Makes sense conceptually. What else?
A lot of focus on supplements and natural compounds.
Mm-hmm.
For OCD and anxiety symptoms, you might see things like curcumin, inositol, sometimes at quite high doses, CBD oil from hemp, passion flower, lithium orotate, a low-dose form of lithium, GABA, magnesium, B6, lemon balm, saffron, motherwort. Quite a list.
Wow, yeah?
Then, if co-infections like Lyme or Bartonella are suspected, specific herbal protocols might be suggested, things using Japanese knotweed, berberine, cryptolepis for Bartonella or Artemisia, grapefruit seed extract, stevia for Lyme. For acute viral infections, sometimes protocols involving high-dose vitamin A, D, zinc, L-lysine, monolaurin, olive leaf are mentioned.
So a real mix of nutritional and herbal strategies. Any other modalities?
Yes. Beyond supplements, you might see mention of certain conventional medications used off-label, like antihypertensives or anticonvulsants, sometimes neuroleptics, or tetrabenazine for severe tics or movement issues. And then, of course, non-pharmacological things like continuing with therapy, CBT, ERP, specific imprintantic therapies, acupuncture, physical medicine approaches, meditation, mindfulness, and exercise are often incorporated.
It really highlights how varied the treatment landscape can be, especially when you move beyond the most evidence-based approaches. I remember seeing a forum discussion where one parent said an SSRI, Luvox, was disastrous for their child's PANS symptoms, but another found CBD oil led to miraculous improvements in anxiety.
That's a perfect illustration. It really underscores how incredibly individualized responses can be. What works wonders for one child might not work, or might even worsen symptoms in another. It makes this a very challenging area for families and clinicians to navigate.
So given that variability, what are the key takeaways for treatment?
Well, sticking to the evidence-based guidelines where possible is important. For OCD, that means prioritizing CBTERP. For PANDAS specifically, if a child fits the criteria abrupt onset OCD tics, prepubertal episodic course, strep link, a thorough workup, and likely consultation with specialists like immunologists or neurologists is warranted. And for all these approaches, careful monitoring and adapting the plan based on the individual child's response is just crucial.
So as we kind of wrap up this deep dive on pandas and PANS, it feels clear that, wow, the science is moving fast, especially with understanding the potential autoimmune mechanisms.
Absolutely. The progress in understanding the underlying biology, like that antibody research, is really significant.
But at the same time, so many questions are still out there, aren't they? About the full range of triggers, finding those definitive diagnostic tests we talked about, and figuring out which treatments truly work best for which kids.
Exactly. There's still a long way to go. The experience of families dealing with this really highlights how much we still need good, well-designed research and very collaborative care between different medical specialties.
This whole area, sitting right at the intersection of infection, immunology, psychiatry, it's just a powerful reminder, isn't it? The brain isn't working in isolation. It's so deeply connected to the entire body, the immune system.
It really is. It makes you wonder what other connections might be out there waiting to be discovered in areas of health that seem completely separate right now. It's a fascinating frontier.
Definitely food for thought. We really hope this exploration has been insightful for you. Thank you so much for your support and for listening to The Deep Dive.
Yes, thank you.
And to learn more about how Luma Clinics might be able to support you or your loved ones with mental health needs, please do visit our website at www.lumaclinics.org.